I think that all four of you have expressed a common theme here, that this is an underserved population. So Judy, from your perspective, the Center for Policy and Budget Priorities, we know that you all have widespread and tireless efforts working on behalf of the underserved. Have CBHCs been a part of your portfolio to date?
Not really. So, I mean, only yes, because I got to be aware of them in talking to you all. And I would say, and this is somewhat of a challenge to you all, I have, since I learned about them, I've been asking other people that are in the broader Medicaid advocacy community, both national and state, you know, and even some government policymakers, have you heard of the Excellence Act? Do you see, you know, how this can feed into the conversation around expansion, around improving the delivery of care? And I would say that I've been getting blank stares from most people, and I think it is really such a huge thing, and you know, particularly listening to Senator Stabenow and the effort to broaden it immediately. But I think if you heard about community health centers being a pilot and think about where they are, and then, of course, taking the challenge of not wanting to wait 50 years, I do think that I would say that this conversation has to be made much bigger to incorporate a much broader group of people that are working every day in the same way as many of you in the room. And, you know, we would be happy to do whatever we can to help with that.
Thanks. We certainly appreciate your efforts here. Linda, from the perspective of National Council, what do you believe needs to be done to more widely publicize an understanding of the benefits of the CCBHC?
You know, I think what Judy just shared, asking people and getting blank stares back, is exactly the experience we have. In fact, it's spot on. I think one of the issues is this isn't simple and it's not sexy. And it's hard to pare it down into simple and sexy terms. And there's a lot of noise in the system, right? I mean, if you look at what Medicaid has done and continues to do in the sphere of innovation, it is startling, in fact, mind-blowing. When I go around and people tell me their state Medicaid director says CMS won't let them, I say, I don't think that's true. CMS is allowing tremendous innovation and, in fact, supporting it. So I think it's how do we get through the noise? How do we begin to describe this in a way that's simple and sexy? And we have not spent a lot of time in trying to do that. I think we've been so involved in other parts of this that now we have to turn our attention to the marketing piece. And I think the third piece is, and this is human nature, is people don't necessarily own this. So many advocacy groups have their own agendas, and they're good agendas, but they're going to focus on their agenda. So how do we get this to be everybody's agenda and for everybody to feel like they're going to benefit and be part of the action?
Okay, thanks. And Dan, from a criminal justice perspective, what do you think the engagement is with the CJ community around CCBHCs?
I hate to echo the blank stares comment, but you know, we're Cochs is very blessed to work with people from all sides of the criminal justice system. So we work just as much with prosecutors as we work with public defenders. We work with the National Association of Drug Court Professionals, which brings together so many practitioners in order to try and get people into substance abuse treatment instead of having them enter the criminal justice system and be in jails and prisons. And anytime I ask one of them, have you heard of the Excellence Act, or Section 223, as it's also called by our federal partners here, have you heard of the Excellence Act? And the look, they say, no, I've not heard of it. And you know, I think it isn't simple, but I do think it's very sexy. Yeah, I certainly do. You know, when the way I got into Cochs is not only just recognizing the disparities in the criminal justice system, but also recognizing that I have an aunt who has schizophrenia, and that when she is having an episode, because she's a white woman from an upper blue collar family, The police, when they come, which is a problem in itself, that the police are the first responders. When the police come, they take her back to her family who's there. That's not the same situation that happens for everyone else. And so when I tell my parents, when I say, you know, Aunt Claudette, if she were in an urban environment and she were black, you know that she would not have the same outcome. And they get it. And I say, now there's this opportunity, and what we're working on now at Cochs is to try and let people know that there are opportunities out there in order to connect these folks with care. And my parents get it. And neither of them went to college. You know, my dad's a steel worker, my mom worked at Burger King, and they get it. So I think it can be made very simple, it can be made very sexy, and people really, the criminal justice hook to it is so incredibly powerful and so incredibly strong. And what we just need to do is be able to get the word out there. Part of the problem is the short time frame on this. We do not have much time to get the word out there. But keep it simple, keep it sexy. That's my motto.
All right, all right. So kind of, what do you think needs to be done to ensure that the benefits of CCBHCs are better understood?
So I think we're still waiting to see, right? I think that we feel very confident that there will be a great deal of benefit from the CCBHCs, but we are in a building phase. We're still planning, and I think the evaluation of the program, of the demonstration, is really vital to make sure that we're measuring the right things, so we can demonstrate the net impact, that we're just not measuring processes or outputs, but that we're really able to capture what the impact and the net benefit is to communities. In addition, or sort of in the meantime, I think you asked, Linda, also how are we getting the word out about CCBHCs? While they are a fundamental part of the demonstration for Section 223, we'll continue, SAMHSA will be doing technical assistance to states and communities who want it to better understand what we've identified as a model for care in the community. And so other states and communities and providers will have an opportunity to learn about the criteria, to learn about the financing and the accountability that's going behind 223 and the quality measurement, so that if and when it becomes the law of the land, we'll have lots of folks ready to sort of step in and join the party.
Okay. So now we'll open it up to the audience for questions.
My name is Mark Stern. I'm a correctional physician at the University of Washington School of Public Health. So I have a worry, I have a concern. One of the components we haven't talked about so far is if we make mental health services available, we have to have the resources, not the money, but the people to deliver those services. And I have a fear that we may not have enough psychiatrists, psychologists, other mental health workers in the United States to absorb the new workload. So I'm going to ask the panel and the audience, does anybody share my fear? And if you do we have a national strategy for making sure that we have enough healthcare providers?
So, you know, I can start. I certainly share your fear. I think it's not a fear, I think it's fact. And I think part of the solution will be technology, in fact. We have our own member organizations, behavioral health organizations, who've developed telepsychiatry capacity, both for themselves and now are contracting with other organizations, really across the country. But it's not enough. And I think part of it is that we've made healthcare quite unappealing as a profession. You know, I was listening to the radio a few days ago, and GE Capital said their biggest problem is workforce. When you look at our low unemployment rate relatively, and you take that unemployment rate and you look at the unemployment rate for skilled people, it is even far lower. So we're in a very competitive world for the millennials, right? And the problem we have is what we say about healthcare wouldn't make anyone want to be a practitioner or a provider. And I think a lot of the things we do add burden rather than relief, and I think we have to think about that. Just one thought.
COP's annual conference for chief psychologists. I was an invited speaker as a person who had been in prison and what worked and what didn't work. And I can tell you that at both the prisons I was at, we lost our psychologists. No one wants to be a psychologist or a psychiatrist in a prison. So it is a real problem and it is a real concern. If we're going to incorporate trauma-informed care across the board, we have to encourage the people that are getting their PhDs in psychology that there's a need in the prison and make it sexy, as you say, and demonstrate that it works. But there is a shortage. I'm living experience of that I spent the last 3 months of my time in prison, on 6 weeks of it, on suicide watch, and there was not one psychologist. So it's an issue.
Okay, anybody else want to comment on that?
So I would concur with the assessment that there is a behavioral health workforce crisis. I think Department of Labor has identified behavioral health as one of the fastest growing professions as a broad domain for the nation. And I think there are several ways that we're trying to address it. In 2014, SAMHSA, as part of the President's Now is the Time initiative, had added $25 million to our workforce, behavioral health workforce program, where we were focused at that time at master's level and paraprofessional and PhD psychologists. It didn't include physicians. We did also double our minority fellowship program, however, which does include psychiatry. And in 2016, we proposed to double that program, double the behavioral health workforce education and training program that we administer, that HRSA administers on our behalf. And in addition, HRSA has put a major investment in the National Health Service Corps, and we've seen, I think, is it 25% of the providers in the National Health Service Corps are identified as a mental health or substance abuse professional. But I think it's not just about producing new professionals, because the need is now. And so we have to use creative strategies to make the most of the professionals that we have. So looking at innovative models. I mean, telehealth is one thing, but even telehealth, an individual can only see so many other individuals, whether it's virtual or in person. So we have to look at things like collaborative care models, like Project Echo, where you take the super specialist and they can support other specialists, or you take specialists and they can support non-specialists to extend the care, because it's true. Not everybody wants to work with a certain population. Not everybody wants to work in a very rural area. Not everybody wants to work with children, and so we have to figure out a way to imbue those people who do want to work with those populations with some of the knowledge that could help them deal with their mental health or substance abuse problems. So, thank you.
Great. And one thing I do want to say just about how the CCBHCs are structured themselves, telehealth is a central component of it. Peer support is a central component of it. So we are really seeing that the CCBHCs are trying to address this problem just in how they're structured. And at the same time, they are embracing what really is the future of medicine, which is a reliance on paraprofessionals, a democratization really of the healthcare sector. So we're seeing that, and the CCBHCs are thankfully ahead of the curve in just trying to establish themselves that way.
Yeah, I think there's an effort at multiple levels with not just the psychiatrists, professionals, but with the paraprofessionals in terms of the peer support and community health workers. So there's something being done. Of course, it's not enough. Yes, ma'am.
Thank you. That's a very great question. I wanted to bring up the issue of accountability. Specifically, you can have the providers that we have now, and you can double every single mental health provider that we have available in the United States, and it would make a negligible impact according to the need. So while I appreciate those efforts, if we're looking at a substantive and scalable model, then we need to identify the standards so that they can be broadly implemented. For example, I can tell you that studies show that 90% of pediatric specialists do not follow the posted clinical guidelines by the American Academy of Pediatrics that require, before any medication for behavior is administered, that clinician has to prove that ABA has been exhausted and has been found to have been ineffective. And after that finding is when the patient is eligible for medications. We are now over-medicating toddlers, and our senior citizens with dementia, because the answer is always a pill. And what we're suggesting is the standards that the science has. There's standards that are already set in our nation for priority behaviors. This is how we respond to Baker Acts, or when someone is showing, aggression and violence and property damage. But we also, curiously, have priority 3 behaviors, and those behaviors can be managed ethically by a consumer. And so what we did is we coded the science to be able to scale priority 3 behaviors and so that a consumer can manage them themselves. And whether it's with an oversight of a clinician, if one happens to be available, that's wonderful. But what answer do we have for the people who don't have that access? And with regard to the ACA, it was specifically, as much as it alleges to suggest parity, with regard to EHR and when the insistence is that, when we pay for technology, it can only be related to medical. We're still maintaining that disenfranchising model, because until we support technology or reimbursements for technology that either increase access to care and treatment, that our government would still be able to glean the same information that you would get from a clinician. If you have a system that could pass a Turing test, that a consumer with absolutely no training whatsoever can produce the same reports, clinical and quality measures, to Medicaid, then that's something that isn't being addressed, and I would welcome that it were.
Well, we really appreciate your question, but I think there's structure and criteria in the Act that kind of addresses that. Would any of you like to speak to that?
Yeah, I think that, I don't know, Connie, this is your baby, I don't know if that, so I definitely appreciate that question. The great thing about, again, the CCBHC, it's not just a new provider, it's a new provider type. And what that means is that there are different requirements for it. So part of the CCBHCs, you're going to have requirements to work with different providers in the community. You have to take their data and you have to include it in your system. And so there are quality metrics. There are different ways that this is being measured, and this is baked into the system. So they are going about this in a way that says, how do we actually, from the very start, structure the data in a way that we can actually hold folks accountable and get the right types of results. And then a second thing I heard you say was that we need to start looking at different technologies that are actually empowering consumers. That's 100% correct. And the CCBHCs, because this is going to be a prospective payment system, the rate is going to be set based on the costs of the clinic. This is an excellent way to bring in all of these technologies that are, at the end of the day, going to lower what the costs are for behavioral health. So all of these things are, thankfully, baked into the Certified Community Behavioral Health Centers clinic system.
I think quality and accountability are core elements of the CCBHC requirement, so it is being addressed.
Thank you. My name is Jeff Coots. I work at John Jay College in New York City. So with these concerns, I have a fear of my own that I wanted to put on the table. So with these concerns about capacity, the providers are going to be in a position where they can choose their clients. And so my fear is that this whole system can roll out and be built and not actually end up serving a criminal justice population or justice-involved population. So I'm wondering if there are requirements in the bill, if there are thinkings, what we can do as we roll this out to ensure that there are enough providers that are willing to engage with those populations. And we see this challenge in housing, particularly in New York State, where they put a quota in the system in the New York Housing Agreement, and still the providers were screening out those with histories of justice involvement out of the lottery system. So how can we ensure that not just in the policy level, but actually in the provider level, people are willing and able to serve the criminal justice involved?
Another good question, but I think also in the Act, as Connor mentioned, there was collaboration with a number of stakeholders that attempted to address that, and it was included in the Act.
Yeah, the criteria require partnership with criminal and juvenile justice systems. So I think that, and as well as access to legal services and other social services. So I think that it is, I don't know in terms of if there are bad actors who want to sift out and cherry pick clients, exactly how we would go about an enforcement process on that. But I don't, maybe you guys have a better answer to that. But I do know it's conceived as a fundamental part of the population.
I'm a lawyer, so I say sue them. I mean, yeah, that's...
I agree. I think lawsuits are very powerful. But in addition to that, I think you raise a valid concern, in fact. And it's not always because providers intrinsically are bad. You know, I'm also from New York, and we had a huge issue around housing, unconnected to criminal justice, actually. One of the issues is risk. And the fear of risk, right? I'm going to take on this risk. Something's going to happen, because some things do happen. And in return, what's going to happen is I'm going to be skewered in some way. And so we literally took control away from the providers and centralized the access into housing, assertive community treatment, the really high-end, expensive services. Now, I'm not saying that we can do that around this issue, but certainly what I come away from today, in addition to the National Council having to do a better PR job around CCBHCs, clear and loud, is the whole issue of race, class, and privilege, as well as criminal justice. And will every center have the capacity or the skill to treat people coming in or in danger of criminal justice involvement? There are some clinical skills we need to have. And I think we need to, as a group, begin to grapple with that and take that on. I think this population is different than the population that we historically were created to serve when people who had spent years in state hospitals came out of state hospitals. And I think it requires a different connection to the community and a different set of skills. And we have to take that on, and we will.
I would just add, there are some SAMHSA staff here, Cindy Kemp and Dave Marcet, who know this stuff much better than I do. But I think that the providers are also able to designate certain parts of their population as higher need, and so that they would be able to be compensated differently so that, for taking on more risk.
I think it's a great question, and I think that historically it's a very tough population to serve. It's a very tough to engage, to get behind bars, to start the process. I'm Richard Chiola, by the way, from Beacon. And 20 years ago, it's sort of like, you really, I'm going to provide housing for those folks. But in this era of managed care with ACA, with expansion, there's going to be an expectation on the health plans. So just for a moment, think about this, that it's a leadership issue. That is to say, it's a state leadership issue that says, these are Medicaid dollars. I'm the commissioner of mental health. I'm the director of Medicaid. I'm the commissioner of drug and alcohol. If you want these Medicaid dollars, this is the way that we expect you to perform to the health plans. The health plans then have an obligation to translate that expectation to their providers. It's pretty clear, and there's got to be a way of targeting providers, and not all providers are going to step up and be able to do this. This is not easy work, right? So then goes to the issue of compensation. So it starts with leadership and vision at the state level. Ultimately a good payer makes a good program, right? It's like, that's the only way it works. You got to start at that level. You convey those expectations to the health plans. You incorporate the cost of doing these right services, whether it's outreach and engagement. You incorporate that into the capitation rate that's coming to the plans. And you say, guess what? In exchange for this capitation rate of $800 PMPM for behavior, this is who you're going to serve. If one of your members is in trouble, we expect there's a crisis intervention team that you're contracting, part of your network, is going to intervene, going to work with the police department, talk about crisis intervention training, talk about de-escalation, and talk about diversion, not just from the hospital, not just from the ER, but from jail. If you miss that opportunity, then you're going to work with the clinics, your court clinic, and you're going to be ensured to help the judges make the right decision that they want to make. If you miss that opportunity, the person's behind bars, you have an obligation health plan with that capitation rate to send somebody behind bars to work on a pre-release plan. And then guess what? On the reentry side, one of your providers better be there to receive that person, to ensure the sustained support that occurs to capitalize on the gains that were happening behind bars. It's all part of the expectation. And basically, those who are controlling the resources can make those expectations. Providers have to be paid differently. So you're not going to get this on a fee-for-service rate of $45, per. It's got to be you're going to pay for outcomes. You got to make it worth providers to step up, whether it's paying for outcomes or prepayment or case rates. But you've got to target providers that can do it. You have to pay them appropriately. The plans have to be held accountable, but they need the capitation rate that's going to bring that about.
So can I just piggyback? That was, I think, fabulously said, but I want to piggyback on it because I was having a conversation earlier with some of Connor's staff about this. And I think one of the important things is, as the states are planning, that they're looking at the population they want to ensure be served. I'm afraid they're looking at the same 10 people that they have been serving all along and thinking this is a shift of dollars potentially. I think this is not the same population, not the same issues, and I think that conversation, and I have to say, even more than state mental health authorities or substance use authorities, probably the sharpest people right now are the Medicaid authorities. That conversation has to be had with them as well.
I would totally agree with that, and I think what you stated was so right on in terms of the fact that this conversation does have to be broadened, because I think if everyone doesn't understand this and buy into what the goal of the folks in this room is, what it's going to come out as is this is a way for states to save money, right? This is a way to kind of supplant some of the funding they've been already providing. So the integration with the managed care plans is essential, and making them understand that, right, what this does is boost their rates, right? Because if they see this is just something they have to do with the same amount of money, it's not going to work. So I think what you just stated is really a very key agenda for this to move forward.
Anyway, hi, I'm Bob Balicki. I'm a warden of a small county jail in New Jersey. First off, I want to thank Cochs for what you're doing. I'm excited to get involved with this. The blank stare, I have it too. Because I'm a warden, I'm busy with lots and lots of things, so I can't get into the weeds of all the particulars you need to do. So I want to ask for two things. One is, because of the guidance and mentorship of Cochs, I have a reentry unit that is excellent and a drug and alcohol program that's excellent. And I reduced the count in my county jail from 700 inmates to 350. And because of that, we had empty beds. We were able to merge with another county jail that closed itself completely. And I closed my juvenile detention center. I used to have 48 kids in there. We ended up with 5. And so I saved the county $5 million. So here's the first one I want to ask. I got to beg for a piece of the $5 million because there's so many needs all over the place that they just swooped that up just like it was a Christmas gift. So I would like some assistance and just a percentage of it. If we do what we're supposed to do and it results in what it's supposed to result in, don't take all my money. Yeah. I want a piece of that. Second thing is, I would like some training available so that I can send someone to become a militant advocate for what you're trying to do, so that they know enough about it that they can come back to me and say, all right, here's what you got to do, Warden, and I'll get it done.
So before you answer that, I have a postscript to that. It's a great question, Bob, and thank you. After lunch, we're going to hear from a prosecutor, another warden, a drug court, and someone who runs a substance use disorder program on how a CCBHC could actually change their census and change their lives. And I think Bob's an example of where we figured out how to do that in his county in New Jersey without extra reimbursement, with creative leadership. And I think the question I want to pose is we've all been talking about these opportunities. I think what Bob just hit on the head is the extent to which he, in his day-to-day life and his day-to-day commitment to de-incarcerate the folks that otherwise would show up at his facility, how do we make that hook? How do we move from this idea of opportunities to making it work in his county, in Cumberland County, New Jersey?
We were talking earlier about how hard it is when people are really busy to get them to be those militant advocates. And I think that is totally understandable, and it's really hard, and even in, my day-to-day work, I feel like I never have enough time to read and do all the things that I get inspired to do when I come to a meeting like that. So I do think it's what you said at the end, is we have to figure out, is there a way we can support the advocacy as a part of this? And I don't really know what the sort of funding stream for that is right now, but I think, I don't know. It sounds like something a foundation could really do. I mean, I think this is sort of very clear that we need to build on top of all this. What you said was astounding to me, and it needs to be brought out. It needs to be lifted up. That example needs to be out there on what you can do, and then you need to be kind of the person telling the story because you did it.
So Judy was the first person to mention the word reinvestment in years that I've heard. People are actually, I think, ashamed and afraid to mention it, because the thought is we're going to save money if you give us money to do treatment, but we don't deserve any of that back. And I think that in itself is a game changer if we begin to try to talk that language and not be afraid to say, we want a percentage back for the things you want to do. And it's really to have a reinvestment plan. Last week we hosted, there's an initiative called Stepping Up, which is to reduce the number of people with mental illnesses in jails. And the one thing, and they have some, numerical goals, but they're not talking reinvestment. And I think that's a missing piece. So I'm certainly going to take that away as something to consider and think about.
Yeah, and at the Center on Budget, we work with a network of state-based groups that work on tax and budget, which is really our mainstay, and they're starting to work with a number of other groups on the whole ending mass incarceration. And I think one of the things that they're thinking about as with the state budget advocates is reinvesting those savings into the communities to basically keep people from having to be in jail and prison. So I think, your example is just so telling that you would have to fight for the money you save to reinvest to really keep what you're doing going. And I think that maybe is part of the framing that we have to adopt.
So another frame on that is in California, we passed something called Proposition 47. And Proposition 47 took substance use issues which were previously a felony and made them a misdemeanor. And in that citizens' proposition, there was a requirement that the savings be reinvested in treatment. I think when we hear our panel this afternoon, you'll have 4 individuals, a prosecutor and everyone else, every one of whom is as committed as Bob is into ending the epidemic of mass incarceration. And I think if we all agree that CCBHCs are going to be an integral part of ending that epidemic of mass incarceration, Dan, going back to your story of generationality, without reinvestment, we won't be successful. And I think that's a really important message to understand. And I think, Khana, that's where the leadership of you and your folks at SAMHSA have been so important in understanding that a non-four walls model is crucial to what it's going to take to end the epidemic of mass incarceration. And I think that this afternoon after lunch, it'll be really powerful for some of us to hear from a prosecutor how devoted Jean is and what she's looking for to end the epidemic of mass incarceration and how a CCBHC would change her path. So I really appreciate that.
So, Bob, I think your Christmas gift pain is shared by a lot of folks around here with jurisdictions grappling for budgets and all, and having budget shortfalls. They're pulling money from wherever they can. But I think to elevate it up to your political stakeholders would be a good step there. All right, so.
What about?
Sorry.
We'll do 2.
So this is a good panel to pose this to, not to put you on the spot, but Judy in particular. Talking about reinvesting some of the funds, I think it's worth putting on everybody's radar, and I'll sort of ask Judy to maybe dig in a bit more, if you could, on the upcoming 1332 waivers and the opportunity for state Medicaid agencies to sort of scale up things that may or may not include notions like the CCBHC and other opportunities to look at innovative care delivery models at the state level. I just sort of wanted to make sure that we had all of us had that on our radar, the 1332 waivers, so go home and Google it, that it's coming and hopefully can support some of these holistic approaches. So.
So 1332 is actually an authority to waive the parts of the Affordable Care Act that are not the Medicaid parts. So it's, you know, it's the premium tax credits, it's all of that. And I think for, you know, we and many other groups have really been looking at it. It's not quite as broad open than I think it is. And I think it can be coupled with the authority in the Medicaid statute for waivers, which is 1115. And, you know, you can think about, you know, streamlining coverage. But I think the real opportunities to do the kinds of things we're talking about here are much more in the things like the Excellent Act and a lot of the new options and existing options in Medicaid to be much more flexible. And I totally agree with Linda that, you know, anybody who says you can't do that, you know, come back around, other than work requirements and high premiums, and because we will definitely say you can't do that. But I think innovative models of delivery are really going to be much more on the 1115 Medicaid side than 1332, which, you know, I think is a little bit more limited in terms of the population that's directed, as well as the true flexibility because of the constraints, I mean, of having a, you know, a tax-based system of providing subsidies. So I think, you know, time will tell, but I would look more to the Medicaid side as the place where innovation can occur.
So before we leave that, can I just ask you to briefly explain to folks who may not understand it, how 223 has a waiver authority within it that might apply to some of the stuff we're talking about, both services outside the state plan?
I would probably need one of my folks to explain that.
Wait, let's get a mic on him.
Can I?
David, could you just explain how, one of the things I think people should understand, how CCBHCs can provide services outside the state Medicaid plan, that's particularly important in terms of criminal justice.
Yes, I can explain it a little bit. I'm no expert at all on Medicaid, but my understanding of the funding for the Medicaid for the CCBHCs is that it's outside of the waiver system. So basically, it's the program itself that's being funded, and the services within the CCBHCs are funded under a special, what's it called, special funding mechanism. Yeah.
So in effect, I'll do it. So
You'll do it.
in effect, what happens within the Section 223 CCBHC is that your state does not need to have an 1115 waiver in order to target the CCBHC services. So if the CCBHC deems that it needs to provide a service that's not covered by the state Medicaid plan, it can do that under the CCBHC authority. This is something very unique that Congress gave to CCBHCs, that you do not need to go through the normal state plan process. Where that plays out is in some of the discussions that we heard Lisa talking about peers. So you may be in a state, for example, that does not cover a community health worker as a Medicaid provider. As a CCBHC, the kind of results that Lisa showed in her bar graph on decreasing emergency room use, you can go ahead and use a Medicaid dollar to cover that peer provider to do exactly what Lisa was describing and use a Medicaid dollar, a very unique attribute of CCBHC that, Bob, will help you out a great deal in the kind of work that you're trying to do in Cumberland County. So I just wanted to make sure we put that on the table if we were talking about waivers.
So one last question right here. He's been standing for an hour.
My name is
Steve.
Gabriel. Thanks. My name is Gabriel Saya. I'm with the National Support Bureau for Law Enforcement Assisted Diversion. My question is about the tension that, and this is sort of not in the weeds about the technicality aspect of the funding piece here, but because the ACA acknowledges that substance abuse and substance abuse disorders is a health issue, but we still have a policy apparatus that criminalizes people for addiction and drug use. How do you see this playing out with care providers in this context, and do you think that there's a role, particularly for behavioral health providers, to start talking about the need to decriminalize behaviors, potentially decriminalize drugs, because the shifting the funding is going to be important, and allowing for the behavioral health aspect to be supported is an important aspect to ending mass incarceration. But we're not going to end it if all we're doing is moving money around and not actually decriminalizing people and their behaviors. And so I wonder if you could talk a little bit about that. And my concern in this that I'll embed in the question is the extent to which the criminal justice model of treatment is anchored in abstinence. And so the drug court model anchored in abstinence, it's got fairly significant problems with that. How do you see that playing out as well in terms of this process, and what role, if any, do behavioral health providers have in being a voice to call for those types of changes to occur?
Great.
Starting in Senator form.
I guess that's me, yeah. That's an excellent question, Gabriel, and I really appreciate it, and thank you for your patience as well. You're absolutely right. I mean, we do need to rethink the way that we do our drug policies here in the United States. And the good news on that is that it is already beginning. We are seeing sentencing reform. We're trying to get rid of mandatory minimums for certain things. The problem is that this is a rheostat. It isn't a dial. There are so many people out there who believe that individuals have addictions because of moral failings. And I think that what we have to do is we have to prove those people wrong. We have to prove that these individuals want the opportunity to be able to participate in society with the rest of us. And the CCBHC is the hook for that, or substance abuse treatment is the hook for that. Because once we start recognizing and once we start seeing the folks who say, I was in prison because of a substance abuse problem. And now here I am out here telling you today that I'm a member of society with you. I am totally equal with you, and I deserve just as much dignity as the rest of you have. That's a powerful statement. And so thankfully, I think that we are heading in that direction. I think Prop 47 is an example of us moving in that direction. But again, we are still facing that there is a lot of stigma around substance abuse. So hopefully that's going to change, and thank you for that question, and I hope that we'll all advocate for that.
So I want to thank the panelists for an insightful presentations and comments regarding this. And finally, as we close, just ask Connor, with as many partner federal agencies that might be out there, would it be comfortable for you to have them reach out to you for guidance? Okay, y'all hear that? Okay, follow up. All right, so now we're going to break for lunch. It's going to be downstairs right outside where the breakfast was, and kind of put wheels on it so we can get back and get in place before our keynote comes, please. Thank you.